I, more often than not, will treat an adult's symptoms of inattention off-label, meaning that I don't believe that they have ADD or ADHD. There's no historical evidence to indicate that. And their mental status examination is also not consistent with it. I'll often let a patient know that I don't believe that their history, that their symptoms, the nature of their symptoms, the severity, the context in which they occur, all of that together with their mental status does not lead me to believe that they most likely do have that condition. But if they're having target symptoms, or if they simply wish to improve upon their productivity and to improve upon their ability to get their work done and to be more effective, then I'm perfectly willing to treat those individuals with reasonable doses if there are no contraindications. And that would be, obviously, if a person has amphetamine or methamphetamine use disorder, where they can't control taking those substances because they have an addiction to those substances, that's an absolute contraindication. Sometimes we can try to use non-amphetamine products or even Wellbutrin, which is a dopaminergic, noradrenergic antidepressant that has no abuse potential in those cases. Another contraindication would be a poorly controlled seizure disorder, in as much as stimulants lower the seizure threshold. So I wouldn't prescribe any kind of stimulating substance, including Wellbutrin, if someone presented with epilepsy that is poorly controlled. And there are other contraindications. Bipolar disorder is a relative contraindication. If an individual becomes manic or hypomanic spontaneously and also suffers from major depressive episodes in between those manic episodes, it is relatively contraindicated to use a powerful stimulant, or at least the most powerful stimulants. And psychosis is another absolute contraindication. If a person is already paranoid or delusional because of a primary psychotic disorder such as schizophrenia and that spectrum of disorders, then treating ADD or putative ADD is contraindicated. It will exacerbate their paranoia. It will potentially cause hallucinations or exacerbate pre-existing hallucinations. And you have to prioritize treatment. You have to understand that in syndromes like schizophrenia, negative symptoms, especially cognitive, are part of the syndrome, and they get worse over time, and you would never treat those with a stimulant in an individual with schizophrenia or schizoaffective disorder. And impulse control disorders, people that experience panic attacks or rage, if it's poorly controlled, then there's an absolute contraindication to the use of stimulants, off-label especially. If panic attacks or anger management problems are well controlled, or for that matter, hypertension is well controlled, then we can proceed cautiously. But in offering treatment, pharmacologic treatment to patients, it's always a risk-benefit analysis. Regardless of what condition we're talking about, we always have to weigh the potential adverse effects of taking a medication with the potential benefit to the patient of treating its target symptoms and the side effects that are induced from treating those target symptoms pharmacologically that are of concern. With that said, I will treat off-label if the patient is a good candidate for treatment, which is to say there are no pre-existing medical conditions that serve as contraindications. There is no indication that this individual has a stimulant use disorder. It's not a contraindication to treat off-label if someone has had difficulty with alcohol or sedative hypnotics, although I do proceed with more caution in any individual with chemical dependency. But if an individual has a healthy lifestyle and is euthymic, that is to say not depressed or clinically anxious or having other problems with mood, if they're cardiovascularly and otherwise physically appropriate, to give them a medication that's going to increase heart rate and blood pressure and that will put a strain on the cardiovascular system, if they don't have any neurologic conditions that might result in greater risks and problems than benefits, and if they are honest, reliable historians, if they are not consciously trying to mislead with their request for treatment, and they are honest in follow-up, then there's really no problem treating an individual as long as we're not causing more problems. And if I'm managing that medication, I'll make sure that it's not backfiring in terms of irritability, insomnia, and those more serious psychiatric symptoms. But also, I'll make sure that we don't end up on doses that are dangerously high.